Bismillahir Rahmanir Rahim. Our lecture today, which is the second lecture in the Pharynx, is the disorders of oropharynx. First is the soft palate disorders. Cleft palate, which is due to the failure of fusion and associated with a characteristic voice change, rhinolalia aperta, and nasal regurgitation of fluids. There is also a Eustachian tube dysfunction, which is due to the failure of tensor villi palatini to open the Eustachian tube on swallowing. Of course, this is a problem mainly caused by the plastic surgery, but there is a strong relation with the disorders of the ENT, like otitis media diffusion and others. Second is the congenital elongation of the uvula. Third is the squamous papillomas, which is very common in oral cavity and oropharynx. Fourth is the Pharynx disease. Also, this is a very common disease, especially in the oral cavity, in which there is swelling of the uvula causing uvulitis, often in association with acute bacterial tonsillitis. Uvular swelling can also occur with trauma like heroic snoring, burn from hot food or beverage. Really, this is a very common problem, and many people, when they saw it, they are afraid of it. But the treatment is very simple, like to take warm fluids, antihistaminics, and sometimes we may need corticosteroids for the very short days. Like this, as you see in this case, and this is associated with inflammatory process. And fifth is the angioneurotic edema. Can occur as a familial or allergic condition or due to angiotensin converting enzyme inhibitor use. Now we go to the infections of the Waldear's ring, internal Waldear's ring. إذا تتذكرون بالاناتومي بالأوروفارينكس شفنا الصورة اللي هي the internal ring, the palatine tonsil, the lingual tonsil, and the adenoid. These are lymph nodes which are involved by many diseases. Many organs can induce inflammation of Waldear's ring. These include aerobic as well as anaerobic bacteria, viruses, yeast, and parasites. Some of the infectious organisms are part of normal oropharyngeal flora, and others are external pathogens. Because the oropharynx is colonized by many organisms, most infections of Waldear's ring are polymicrobial. Now we go to the viruses. Really, we are facing many problems regarding treatment and diagnosis of diseases causing the problems in the or diseases in the oral cavity and also the oropharynx. The classic common cold is the most frequent cause of otolaryngologic infection, especially in children. Many viruses have been implicated in causing pharyngitis, like rhinovirus, COVID-19 virus, a novel virus. As you know, today we are facing this problem, big problem. Influenza virus, para-influenza virus, adenovirus, and many other viruses. Most patients have a fever with erythema of the pharyngeal mucosa. The tonsils have been enlarged, but frequently there is no associated exudate. Management of viral infections is non-specific and symptomatic, i.e. we treat fever, pain, that's enough. Antibiotics are helpful in cases of secondary bacterial infection, and as you know, the antibiotic use in our community is a big problem, as I said previously, and this depends on the health rules, the doctors, and others. I want to take an example of the viral infections, which is very important because sometimes the diagnosis cannot reach, especially because the symptoms and signs are similar to the acute bacterial tonsillitis. This problem or this disease is infectious mononucleosis, or we call it glandular fever. It is an acute herpes virus infection caused by the Epstein-Barr virus. It is characterized by fever, sore throat, swollen lymph glands, atypical lymphocytes, splenomegaly, hepatomegaly, and abnormal liver function. The disease is usually transmitted by droplet infection. Young people are most often affected. In childhood, the disease is mild and usually unnoticed. The older the person, the more severe the symptoms and are likely to be. Infection confers permanent immunity. The diagnosis of Epstein-Barr virus is confirmed by laboratory studies. A differential blood count showing about 50% or more lymphocytosis with 10% atypical lymphocytes and is considered as a characteristic of Epstein-Barr viral infection. Serological studies include monospot and Powell panel test may be negative initially and due to that must be repeated in 1 to 2 weeks if clinical suspicion of infectious is strong. Treatment is primarily symptomatic by analgesics and saline gargles for throat discomfort, with enforced bed rest to prevent serious complications of the liver or spleen. Antibiotics are used to treat secondary bacterial infections. Amoxicillin and ampicillin should be avoided because a rash may occur despite previous intake without similar reactions. See in this picture the infectious mononucleosis, which looks similar to the acute tonsillitis, but there is a membrane on the tonsils, even in rare cases, may be seen also in acute tonsillitis. Now we go to very common problem regarding all branches of medicine. These are the health problems from diseases in the tonsils and adenoids, which are among the most commonly encountered in the general population. Recurrent and chronic infection and obstructive hyperplasia are the most common diseases affecting the tonsils and adenoids in the pediatric population. We go to the microbiology of adenotonsillar diseases. Group A beta hemolytic Streptococcus is classically described as the main bacterium implicated in adenotonsillar diseases. Other bacteria like Haemophilus influenzae, type B, Streptococcus, pneumonia, Moraxella catarrhalis, Staphylococcus aureus, and anaerobic-like bacteroids species are also involved. Viruses are also involved, like Epstein-Barr, as we said, adenovirus, influenza A and B, and herpes simplex. Several new concepts have emerged in the understanding of chronic adenotonsillar disease, and these concepts are the following. First, the presence of polymicrobial infections. Second, the increased presence of beta-lactamase producing microorganisms. 3. The role of anaerobes. 4. The role of bacterial antigenic concentration. 5. The importance of crypt obstruction resulting in bacterial stasis and establishment of chronic infection. Fifth is the importance of crypt obstruction resulting in bacterial stasis and establishment of chronic infection. 6. The disruption in normal bacterial hemostasis, shifting from common cells to potential pathogens. An exclusively viral etiology as the basis for chronic disease is unlikely, although viruses as initiators of mucosal inflammation, crypt obstruction, and ulceration with secondary bacterial invasion and infection are likely to activate the acute infection. Pathogenesis of adenotonsillar disease. The pathogenesis of infectious inflammatory disease in the tonsils and adenoids most likely has its basis in their anatomic location and their inherent function as organs of immunity, processing infectious material and other antigens, and then becoming paradoxically a focus of infection inflammation. يعني the adenoids and tonsils, it is considered as part of immunity, as a defense factor, but maybe the focus of infection, focus of the problem. مثل الجندي على الحدود، هو اللي يحمي ولكن هو اللي أكثر عرضة للإنجريز أو للمشاكل. Viral infection with secondary bacterial invasion may be one mechanism of the initiation of chronic disease, but the effects of the environment, host factors, the widespread use of antibiotics, ecological considerations, and diet all may play a role. Now we go to the clinical classification of the adenoids and the tonsils. First of all is the adenoids. Acute adenoiditis. The acute adenoiditis is particularly difficult to differentiate from a generalized viral-induced upper respiratory infection or a true bacterial rhinosinusitis. Purulent rhinorrhea, nasal obstruction, fever, and often otitis media may be seen. When the acute infection is accompanied by loud snoring, which then dissipates after the episode, infection in the adenoids may be more likely. Then recurrent acute adenoiditis. It is defined as the presence of 4 or greater discrete episodes of acute adenoiditis during a 6-month period. Differentiation or differentiating between recurrent acute sinusitis and recurrent acute adenoiditis may be extremely difficult to make on clinical grounds alone. Radiographs to evaluate the sinuses may be useful. وحقيقة هي هذه فعلا بعض المرات انه الناس الاهل لما يجيبون الطفل فعلا دائما انه الادينودايتس which is more common يقولون هذا ابننا دائما يقولون عنده التهاب الجيوب الانفية. فهو حتى بالنسبة للفيزيشن it is very difficult to differentiate. It needs more evaluation سواء كان يكون endoscopy, X-ray to differentiate the duration to differentiate that this is adenoids or sinusitis. Chronic adenoiditis, persistent nasal discharge, malodorous breath, postnasal drip, and chronic congestion may signify a chronic adenoid infection. Because most of these symptoms also are often associated with chronic sinusitis, differentiation or differentiating between the two is clinically challenging. The association of otitis media may be more indicative of chronic adenoiditis, but less frequently with sinusitis. Now we go to the obstructive adenoid hyperplasia. The trade of symptoms including chronic nasal obstruction, which is associated with the snoring and obligate mouth breathing, rhinorrhea, and hyponasal voice are consistent with nasopharyngeal obstruction by enlarged adenoids. Clinical evaluation, which is very important for any physician when examining a patient, especially the child. Differentiation between acute and chronic function in adenoids from that in the sinuses is a particular challenge because both infections present with symptoms of rhinorrhea, cough, and postnasal discharge. Therefore, a complete otolaryngologic examination, sometimes including nasopharyngoscopy or sinus radiograph is necessary. The coexistence of these two problems, adenoid infection, may lead to a secondary sinusitis, or the reverse is common. Obstructive adenoid hyperplasia is best diagnosed by clinical history and a physical examination. The trade-off obligate mouth breathing, both awake and asleep, snoring and hyponasal speech is seen. Really, we have three symptoms which are very important, not only for the adenoids, but must be differentiated from other diseases. Rhinorrhea, postnasal drip, and chronic cough, especially nocturnal, are common, but they are non-specific, and when present must be differentiated from the following: allergic rhinitis, non-allergic rhinitis, and 3 sinusitis. The classic adenoid faces characterized by an open mouth appearance, flattened midface, crowded teeth, vacant expression, high arched palate, prominent incisors, and dark circles under the eyes is also this symptoms or features is also seen in children with allergic rhinitis or other causes of chronic nasal obstruction. Abnormalities in the maxillary mandibular relationship may be identified, but unless nasal obstruction is or has been clearly present, the malocclusion alone may not be sufficient reason to remove adenoids. يعني the malocclusion sometimes we see in children, not always due to the adenoids, and we will remove adenoids and doing adenoidectomy. When typical signs and symptoms of obstructive adenoid hyperplasia are noted, a lateral neck radiograph is unnecessary to confirm a clinically apparent diagnosis. حقيقة بالنسبة اللاترال دائما بعض الزملاء ياخذوها اللاترال X-ray of the nasopharynx is not very important. If it is possible to do endoscopy and good clinical evaluation, examination, and good history, you can reach to the diagnosis of the adenoids. This child during sleep, open his mouth, prominent teeth, and with snoring. See when we open the mouth and see the malocclusion of these teeth, and also the high arched, you see the high arched palate. See this face, vacant expression, open mouth, prominent teeth, widened face. These are characteristic or classical face or adenoid faces. Treatment. Now we go to the treatment. In the past, the usual approach to the disease in the adenoids has been surgical removal, but careful patient evaluation and the wise use of antibiotics and consideration of newer approach to the treatment of disease in the tonsils and adenoids will continue to the decreasing the number of tonsillectomies and adenoidectomies performed each year. Recurrent or chronic adenoiditis should be treated initially with an antimicrobial effective against beta-lactamase producing microorganisms, particularly when associated persistent or recurrent otitis media or sinusitis. Adenoid hyperplasia also may respond to a prolonged course of 3 to 4 weeks of antibiotics. Surgery adenoidectomy should be considered only after failure of medical therapy. Really, there are some indications, but I didn't mention here. Now we go to a very common subject also, which is the tonsils. The tonsil size is graded from 1 to 4. Sometimes they add 0, but here from 1 to 4. According to the percentage projection from the anterior tonsillar pillar to the midline. Grade 1 tonsil projects 0 to 25% from the anterior tonsillar pillar toward the midline. 2 projects 25 to 50%. Grade 3 projects 50 to 75%. While grade 4 projects 75 to 100%. Tonsils graded 4 are sometimes referred to as kissing tonsils because they touch each other in the midline. Now we go to acute tonsillitis. Sore throat, fever, dysphagia, enlarged erythematous tonsils with exudates, halitosis, otalgia, referred, headache, limb and back pain, shivering, and malaise are classical symptoms and signs of acute tonsillitis. Viral pharyngitis tends to be milder in presentation and usually without exudates, except in infectious mononucleosis, which causes glandular fever, which we speak about previously. See here the acute tonsillitis. Recurrent acute tonsillitis, the exudates, folliculars, we call sometimes acute follicular tonsillitis, acute follicles or exudates of pus. Recurrent acute tonsillitis defined as from 4 to 7 episodes of acute tonsillitis in 1 year, 5 episodes for 2 consecutive years, or 3 episodes per year for 3 consecutive years. Now we go to chronic or persistent tonsillitis. Chronic sore throat, malodorous breath, excessive tonsillar debris, tonsilloliths, peritonsillar erythema, and persistent tender cervical adenopathy are consistent with a diagnosis of chronic tonsillitis when no other source, such as the sinuses or lingual tonsils, can be identified. See the chronic tonsillitis. These are very large tonsils. Here, kissing tonsils, as you see. And this is also large, and there are signs of chronic tonsillitis. Now we go to obstructive tonsillar hyperplasia, when the tonsils are very large. Large tonsils can cause snoring with obstructive disturbances asleep and awake, dysphagia and voice changes, large tonsils by themselves in the absence of identifiable symptoms that can affect the child's health and well-being need not to be removed automatically. If there are no symptoms, no signs, but the tonsils are large, there is no need to remove the tonsils. Clinical evaluation. Acute tonsillitis is the most common manifestation of tonsillar disease, and the diagnosis is made mainly on clinical grounds. Throat culture is the standard method in the diagnosis of acute tonsillitis, and this is a simple and extremely useful test, but sampling must be skillfully performed by swabbing the posterior pharynx and tonsillar areas. But the major problem is the delay in the obtaining the results, 18 to 48 hours. Several rapid tests to detect group A streptococcal antigen in the pharynx have been developed. They employ either latex agglutination or enzyme-linked immunosorbent assay ELISA methods to extract the antigen from a swab. The streptococcal group A carbohydrate may be detected within a matter of minutes. At least this is from the theoretical point of view for us. It is most often treated in the primary care physician's office and is associated with symptoms and signs mentioned above. The tonsils may appear normal sized or enlarged, but are usually erythematous. Often, but not always, an exudate can be seen. In severe cases, a tonsillar or pharyngeal membrane may be found, and this there is a difficulty to and must be differentiated from other problems like infectious mononucleosis by doing white BC differential count or do Powell panel or monospot test. Obstructive tonsillar hyperplasia is currently the most common reason for tonsillectomy. These patients present with varying degrees of obstructive sleep and awake disturbances, which may include symptoms of loud snoring, nocturnal choking and coughing, sleepwalking, frequent awakenings with restless sleep, dysphagia, daytime hypersomnolence, and behavior change, and these symptoms may indicate a condition called obstructive sleep apnea syndrome. This problem we will speak in the next lectures. In children affected by obstructive tonsillar hyperplasia, or we call it chronic adenoma, tonsillar hypertrophy may also suffer from enuresis, drooling, night terrors, morning headache, dry mouth, and halitosis. Sometimes behavior difficulties include hyperactivity, inattentiveness, problems with school performance, and rebellious or aggressive behavior, forming a disorder called attention deficit hyperactivity disorder, ADHD. Treatment therapy has gradually been directed at the aerobic pathogens traditionally associated with tonsillitis, which is group A beta hemolytic streptococci. Penicillin is still the agent of choice in most cases, like benzyl penicillin in a dose of 600 mg 6 hourly in parenteral route for at least 7 days. حقيقة احنا مع الأسف انه جاي نشوف انه زملائنا والأطباء انه ما يستخدمون البنسلين على الرغم it is very effective, and always or in many times I use it and it is very effective. Better than to use ceftriaxone, lincomycin. If there is no response, now maybe shift to other antibiotics. However, anaerobic bacteria play a major role in the complications associated with tonsillitis. So they are probably also involved in recurrent tonsillitis. Anaerobes also have been implicated in acute tonsillitis. Clinical failure of penicillin should lead to the suspicion of beta-lactamase producing organisms. An alternative to the use of penicillin is to use a penicillin plus a beta-lactamase inhibitor such as clavulanic acid, e.g. amoxicillin clavulanic acid, which is in the markets we call it augmentin. Other alternatives are clindamycin, cephalosporins, and a combination of erythromycin and metronidazole, especially in allergic patients to the penicillin. Here we end the lecture. As I said previously, if there is any question, you can contact with me by any way. Thank you for your watching or listening to us.